welcome to our learning channel, MLSQR, Medical Lab Science Quick Review. And today's topic is iron deficiency anemia, an important topic, and stay tuned for the question and answer afterwards. Iron deficiency anemia is the most common anemia in the world, usually because of the nutritional deficiency in economically underdeveloped countries. This also makes it the most common nutritional deficiency in the world, affecting approximately half of the anemia causes globally. People at risk varies from premature infants, toddlers, to growing teens, adolescents, especially females with menstrual periods, because of the increased need for iron. Malabsorption syndromes and chronic blood loss often lead to iron deficiency anemias. General symptoms of anemia include feeling tired, fatigue, weakness, shortness of breath, dizziness, and confusion, feeling like passing out. Besides looking pale with pallor, these patients with anemia presents with pale conjunctiva, glossitis, spooning of the nails, and heart murmurs. Besides, initial lab workup should include a CBC with differential and retic count. The CBC report typically shows abnormalities consistent with a hypochromic microcytic anemia. Notice that besides the low H&H, there is a low red blood cell count, mean cell volume, mean cell hemoglobin, and mean cell hemoglobin concentration, but a high red cell distribution width. When we look at the red blood cell histograms, we see a Gaussian bell curve distribution of the mean cell volumes of all the red cells. RDW is simply a statistical equation to measure variation in red blood cell volumes in a sample, shown in this equation. RDW is usually the first abnormality detected in the CBC in the early stages of iron deficiency anemia, as microcytic cells widens the red cell distribution width. Stage 1 of iron deficiency is characterized by a progressive loss of storage iron, demonstrated by serum ferritin levels dropping over time. Iron stain with Prussian blue stain of the bone marrow will show absence of iron granules. When the iron stores are depleted, iron-restricted erythropoiesis affect the RDW with appearance of microcytes in stage 2 of iron deficiency. Let's see what these iron-deficient red cells what they look like under the microscope. We see hyperchromic cells with a large central pallor. This usually correlates with the low MCHC below 32 grams per deciliter, which is the concentration of hemoglobin concentration in the red blood cell. Microcytic cells are those less than 7 microns in diameter, which correlates with the MCV less than 76 femtoliters. Anisocytosis means that there is a size variation in the MCV, with microcytes as well as macrocytes correlating with an RDW greater than 14.5%. Here's a close-up of normal erythrocytes. In hypochromic microcytic cells, note the central pallor, greater than 1/3 the diameter of the red blood cell. Iron deficiency anemia is the most common cause of microcytic anemia. You can review the classification of anemias based on MCV in my other video. So how does iron-restricted erythropoiesis in the bone marrow affect the red cell changes that we see in the peripheral blood smear? Hypoxia is detected by the juxtaglomerular apparatus near the adrenals of the kidney, which secretes the hormone erythropoietin, which stimulates RNA synthesis of red blood cell precursors in the bone marrow. Hemoglobin synthesis begins with the formation of heme by the enzyme ferrochelatase, which chelates ferrous iron in the 2 plus state with protoporphyrin 9 ring molecules. Then two alpha and two beta hemoglobin chains assemble with the heme to form one hemoglobin molecule. The ferrous iron is needed to carry oxygen molecules from the alveoli of the lungs to the tissues. However, in the case of iron restriction, hemoglobin synthesis does not proceed as normal. Without iron, you have free erythrocyte protoporphyrin accumulating without iron, and also the STFR levels increase. Stage 3 is frank anemia. Depletion of storage iron and diminished levels of transport iron prevent normal development of red blood cell precursors, leading to marked microcytic and hypochromic red cells. And in another video, we will see that in the anemia of chronic inflammation, hepcidin will play a central role in an iron-restricted state where there are adequate iron stores. Further anemia workup warrants more lab tests. And what is your prediction of whether the levels will be increased or decreased? Well, I hope you got your prediction correct. In general, everything points down as decrease except for TIBC, which has increased. And just an FYI, soluble transferrin receptor levels will be high as well. And note that usually bone marrow is not indicated for iron deficiency anemia workup. And if they did do a bone marrow, there's no iron granules with Prussian blue iron stain. And usually they would just give iron supplements and then see the response to the levels before they would even consider a bone marrow. Let's review some question and answers that are modeled after the ACP Board of Certification Study Guide, and they are similar with the concepts but not identical. Thank you for joining us and your support for MLSQR, and